From the Navajo Nation to the Marin Country, he's focused on supporting underserved populations and addressing the mental and emotional well-being of children.
I like working with kids. I like the medicine that we did in pediatrics. And so that's why I became a pediatrician.
It should be done. What does behavioral health integration mean in a pediatric office? What's the story?
Yeah. So oral health integration it's so many different things, right? We're supporting families, we're identifying postpartum depression in moms and dads, all sorts of things. And what we've done is we basically just increased the resources that we have in our practice. So right now we are 2 offices. We're located in Marin County, which is north of San Francisco. We're a suburb of San Francisco. Our practice is primarily commercially insured folk.
And unfortunately, if your Apple is being funded by a program that pays 50% of Medicare, it is hard to find the resources to help these kids. So it's key to have the resources to be able to do the work.
Well, partner with local universities and training programs to provide services to kids. So you don't have to do it the same way we do it in our practice. During the pandemic, she said, hey, my good friend Teresa, who's a school counselor at another local school, is looking to shift. And so we met and we said, I think you've got the knowledge and the experience to help us build what we're envisioning. And so while we hire you, we have to remember that behavioral health integration and our practices are a system. And there are plenty of things in your practice that don't necessarily pay for themselves and increase your ability to take care of your patients and see more kids.
I get paid $150 to refill prescriptions never leaving my house. And there's just no way that I'm going to be able to make that revenue go.
So one of the things, Urban, if you're getting full neuropsych testing done for $3,500, I'll send my patients to you because they'll gladly pay for the plane ticket on top of that.
Oh.
This is the point, is you can't assume that you're going to recruit someone who is in a private practice to come work with you.
It's $250 to $350 an hour around here. And she tells me she's struggling. And the part she's struggling in is that she says the other members of her practice don't want to be in the office anymore. What is running a business that's more like a McDonald's than selling Ferraris? It's high volume. You're not prepared for the client because Johnny could come in with allergies or could come in with a fever or sprained ankle or this or that.
Can you imagine referring to an orthopedist who never sent you a note? Imagine referring to a GI doctor who didn't follow up with you. And yet we refer patients to therapists and to psychiatrists who we don't know them.
The part when they live there in the same building, I've seen that happen. That works well. But back to Herb saying with the medicating the children.
I spoke to Peter in Rhode Island, whose practice has a therapist. I can't remember her licensing right now, but basically all the positive PHQ-9s. That's how the model is set up. Not what we do in our practice, but that's one way that those kids get at least assessed and provided with some resources. We're one of the very few places where they could get therapy covered by insurance.
You're going to grieve, and it's normal to be depressed and anxious in that situation. And we're going to help you through 4 weeks. If after 4 weeks or 6 weeks, you're not rebounding back like you're supposed to, then we're going to refer you to this trusted source because we just don't have the bandwidth to give you therapy for 6 months because there's so many people we need to serve. But that's always, everybody that's been successful says it's a quick thing. It's a quick assessment and we'll follow you up for X number of times. If it goes beyond that, we have an external resource that we can use. But we weren't really trained on diabetes or obesity or anxiety or depression. So do you think there's a room for that kind of model in other disease processes that are becoming more prevalent in the office as infectious disease has waned away?
I tell families that maybe vaccine hesitant or have a lot of questions about vaccines. I have seen in my 30-year career a huge shift in what I do and what I take care of. Social media You can't have a talk about behavioral health anything without talking about social media.
So if you trained before 1990, there were no SSRIs. And the idea of putting somebody on tricyclics was very dangerous. And the family practitioner, the internal medicine doctor, the pediatrician is like, yeah, they need medicine. They need a psychiatrist because these tricyclics are very dangerous drugs.
That's the thing when you start looking at these statistics, I would challenge anyone, if you want to look at the rise in the number of diagnoses for depression and anxiety, it's bet that the graph and the rise in the diagnosis of allergic rhinitis in primary care has been exactly the same, because non-sedating antihistamines and SSRIs.
If you had bootlegged Bactrim in the pantry,
Yeah.
it was made by Roche and it was white. And every time you cough, she would shake it and she'd give you 2 days of antibiotics for nothing. And that's the way the mothers did.
Today's physicians, they don't really have training. Again, they're hesitant, I'm finding, to treat ADHD and give a little bit of Ritalin. Simple old school stuff.
And all you need is a couple of successes, right? Only a couple of kids who come back after 2 months and the parents like, oh my goodness, they haven't been able to get their homework done or their grades are suddenly better for you to appreciate how helpful.
Because they started talking about things.
ADHD was good. The anxiety, the depression was very good. But once they started talking into schizophrenia and OCD and all the esoteric, weird, high level stuff, it's not going to be for me.
Her job is not to follow kids forever. It's to get kids to the point where they're stable enough to come back to us for medication management.
The mental health arena is tough because there are no growth curves. There is no lab test. And a lot of it's intuition. Am I over medicating or under medicating? Am I doing harm by giving this kid clonidine?
The other that is because in primary care, I really feel strongly that this belongs in primary care for lots of different reasons. The same place you come for your sprained ankle is where you come for your social anxiety. So figure out what are your local resources. Start screening. If you've already done those two things, awesome. You're already providing some behavioral health. Find someone in the community who's willing to do what we started with, right? That's amazing. Has lots of great resources. I show it to families in the office every single day.
And they've shown that just that 1 hour of skill building will make a difference in how you feel.
Yeah, finances and sustainability. This is what people want to hear. How can an office get paid to provide this service as opposed to losing money?
You got to think about this as a system. That's number one. The second thing is remembering that you will do more screeners. The financial stuff is tricky and the billing stuff is tricky. Number one pitfall is, can we afford this? Number two pitfall is it's complicated. Credentialing, and does this billing go to the insurance or does it go to the mental health carve out? Mental health and behavioral health for a pediatrician who doesn't have resources to provide and doesn't feel prepared to address it is a huge factor in burnout. I had 15 kids scheduled with lots of gaps for acute care. Obviously, I wasn't going to end with 15, but I started with 15, and 9 of those 15 were ADHD, anxiety, school problems, some behavioral concern. And my experience on that day is not that different from the experience of most pediatricians. And we're seeing a third to a half of the kids on the schedule are coming in for a primary behavioral health diagnosis. Having behavioral health integration is going to help me recruit the doctors. It's going to help me keep doctors. It's going to help me practice longer. And it's going to provide so much better care for my patients.
And they're lasting, on the average, about 7 years post-residency, and then they quit. They don't want to have anything to do with the examiner, which is just alarming. You got 6 kids, no car, no money, no job. You're doing the best you can. We've known that whatever your social circumstance is affects your health because the number one determinant of how long you'll live is your zip code. There is no way this mother with no car, 6 kids, is going to be able to take this kid once a week for 45 minutes to no clinic to get behavioral interventions for 6 months to get his weight under control.